I'm Dr. Deepa Grover. I'm a consultant in HIV and genitourinary medicine in London. And I have some experience of working with an infectious disease and treating an infectious disease, albeit a very different one with HIV infection, because it's a chronic infection, number one. And secondly, it's a bloodborne virus and not a respiratory tract infection. So there are some differences. But there certainly isn't a vaccine after about 30, 40 years of trying to identify a vaccine, but there is treatment to suppress this infection. I think when the Q&A started that in the beginning, 3-4 weeks ago, when Ellie kindly started these sessions, we were really focusing on issues around social distancing and how we navigate ourselves around the infection. And I think the issues are really different now. I think we're looking at how and learning more about how this infection presents and what we can do to support this, and therapeutics and clinical trials, and obviously vaccine development. So my area is really clinical. I'm not currently working with any COVID patients. I'm not an intensivist. I'm not working on ITU, but I'm obviously in touch with my colleagues and getting regular updates and attending training, because we may be redeployed in the future to go to these wards. So I'm happy to take any questions, and I just hope that I can answer them effectively. So are there any questions, particularly around the issues that are current or about the clinical presentation?
So Geeta, can I ask you, I mean, we're talking about, some way off in the midterm of getting a vaccine. I mean, how much of a magic bullet will the vaccine be? Or will it be a bit like, the flu vaccine, that sometimes is good and sometimes, some years, it's not very good? So how will that work?
So, yeah, thank you for the question. It's a great question. I think it really depends on the development and the process. It's going to take quite a long time. I think if it's an effective vaccine, it will work very well and offer protection to lots and lots of people. There are other coronaviruses vaccines. I think that essentially, sorry, I'm a bit nervous. I'm just a bit nervous. I don't really know why. Can you just repeat your question again?
Well, I was asking whether the vaccine will be the magic bullet. We'll all be able to get back to our normal life. It will protect everybody, etc. And I'm not really asking, will the vaccine last for 2 years or 3 years, or we have to do it every year? I'm more intrigued of whether the vaccine is the answer, or whether finding something that will work against the virus rather than assist our immune system. Yeah. Because the emphasis seems to be on the vaccine at the moment.
I think the vaccine is the be all and end all. I really think, this is the magic bullet. The problem is we just don't have one at the moment. We have some candidate vaccines. We don't know how long, like you say, the immunity is going to last for. With the flu vaccine, you need one every year. So is it going to offer lifelong protection or just a limited amount of protection? We just don't know that at the moment. But we do need to have a vaccine, because without that, there are very little data on therapeutics, how to treat this at the moment. There are certainly clinical trials going on in operation, and we do have some treatments that are available at the moment that we're trialing. Hydroxychloroquine, for example, azithromycin, low-dose dexamethasone, remdesivir. These are drugs that we are trialing, but we haven't got any initial results so far. There have been some very small studies, but they've been very short, small number of people, small follow-up. We can't actually deduce any results from these therapeutics at the moment. So prevention is always better, and therefore I do think having a vaccine available is going to change the profile of this infection and how many people get it, obviously.
Thank you very much.
I think it's very, very important. It's certainly been very elusive in HIV medicine, which is the field that I work in, but we now have oral drugs that can prevent transmission of infection. Is that going to be the same for coronavirus? I really don't think so.
Thank you.
Any other questions?
Deepa, masks.
Hi, Danny.
Hi, Deepa.
Hi, Dahlia.
More people seem to be using them. I saw a guy wearing one today covering his mouth, but on not his nose. So very strange use of masks. But is that looks like that's coming in terms of a recommendation, but not. I think that's more to do with not giving it to others rather than getting it yourself.
Yeah,
Even
I mean,
even if you've got like an N95 respirator, would that block the inhalation, for example?
so masks are a really interesting subject. I think it is going to come in. I think it is going to possibly be a general recommendation. It's certainly come in the US and Israel and other countries. So I do think it's coming here. The evidence for masks and whether it protects you is really limited. There is really no robust evidence. There may be some limited evidence to suggest that you may prevent transmission from yourself, but it's not going to prevent acquisition of coronavirus. So they have sort of a limited value. Obviously, there are different, like you mentioned, there's the N95 mask, there's the FFP2 and the FFP3. So there are different levels of masks. And the ones that are used in ITU and in critical care obviously have a respirator attached to it. The ones that we use in the outpatient clinic, or the ones that I'm using, for example, when I see patients in the outpatient setting, is a fluid-resistant mask. So it does trap some infection, but it's of a limited time. These masks can become, standard surgical masks can become damp very quickly. And, once you get to that stage with breathing and moisture, it's really not that effective. But I also feel, it does make people feel a lot better when they're using a mask and when they're sort of next to somebody, and if somebody's coughing and they're wearing a mask, you do feel better in that situation. But the evidence is pretty poor. I think it works. It helps you stop touching your face, which again is an important aspect of this infection. So, hand hygiene and all of that. But I personally think it's going to come in sometime soon, but once they have some data.
Deeper, with the masks, if someone's not wearing a mask, and for example I am, is it still something that can travel into the eyes? I mean, the eyes, I think, are moisture, and if there's moisture in the air, is it something that's only ingested through breathing, or is it something that could equally, come through your eyes? Is that why they use the plastic face covers in the hospitals?
Yes, it can. I mean, it's mainly to the respiratory tract, but I mean, if you're 2 meters away from somebody, then this is the whole idea of social distancing. So I do worry about the mask, that people just have a bit of a false sense of security, that they're wearing a mask and then they might get closer. I mean, this has been sort of said often in reports, but when I'm seeing patients, I am wearing the visor to protect the eyes as well. So I'm not just wearing a mask, I am wearing obviously the gloves, the apron, the visor, everything. But not like the ones in ITU, but a different sort of level of protection. So yeah, I mean, theoretically, yes, but it's a respiratory tract virus, really. So I think it will colonize more in the respiratory tract. So I don't think there's going to be a need for the public to cover their eyes. I don't see that coming. It's really from the ear, nose and throat.
Can I just ask about the social distancing and the 2 meters? And I mean, I saw in the newspapers that, for example, if you're sitting in a car or if you're in a room with someone, I mean, can you catch it because you're inhaling the same air as someone else, even if you're not 2 meters away? I mean, because certainly with the contact tracing they're talking about, if you've been within even probably 2 meters of someone, they're probably going to tell you to go home and isolate. So what is the situation if you're in the same room? Can you visit an elderly person? Like, I don't go into my mum's flat, for example.
Yeah.
because I'm concerned, but I can, if I'm outside,
Yeah.
feel comfortable.
So I think there are two things, Danny. I mean, transmission is also, people say don't go, you know, people are sort of wary about going into elderly parents' flats because, of course, you know, you may touch a surface. You know, we know that this virus does last on surfaces for a certain amount of time. So, I mean, that could be a possible route of transmission. So I think that's the concern with some people. In terms of aerosol, I mean, initially we were told, and I had a talk about coronavirus very early in February when this was sort of happening in China. It is by droplet transmission. Okay, so if you sneeze and the sneeze goes in the air, okay, and somebody walks through that area where somebody has sneezed, it wasn't thought to be, you know, as infectious that you're just, you know, it's hanging around in the air for a long time. That's not the route of transmission for this virus. You actually have to have a droplet land on you to become infected, okay? So I think that the 2 meter rule is if somebody sneezed, there was, you know, the sneeze would not go further than 2 meters, okay? So I think this is where the social distancing comes in for, you know, for that value. How, you know, if someone coughs or if someone sneezes, how far can that droplet be spread? And 2 meters, you know, was the deducted number. So that's the reason why we say 2 meters. I think, you know, not visiting parents. I personally don't go into my father's house because I talk to him, you know, outside on his balcony because I feel that I'm in an area where there's could be potential exposure. I feel well myself. I feel absolutely fine. And thank God I've not had any symptoms and I don't think I've had this virus. But the potential of, you don't know about asymptomatic. A lot of people have this virus and don't get symptoms. You know, is it a possibility? Could I go in? Could it be on my hands? I don't know. I'm very, very careful about sanitizing my hands, etc. But I just don't want to take the risk. So I think it's more about, you know, fomite transmission. By that I mean transmission via surfaces and, you know, objects, as well as obviously the respiratory tract symptoms. Does that answer your question?
Yeah, it does. Thank you.
Deepa, PPE is a very hot topic at the moment.
Yes.
What's your own experience and that of your colleagues? We see the news. Love to hear from a doctor on the inside. What is happening at the coalface on a day-to-day basis?
Okay, so if I'll answer this question in two parts. I'll answer it from my experience of PPP and when we had access to it, and also from listening to colleagues who are working in very sort of highly infectious areas, say in a general medical ward with lots of COVID patients. So in my own experience, initially we were told several weeks ago, no masks. You know, we haven't got masks, don't wear them. You don't need them. And there was a lot of anxiety around this because we were still seeing patients and a lot of nurses were very, very stressed and very, very anxious and absolutely wanted to wear masks. And if we weren't going to wear them, they wanted the patients that we were seeing to be wearing them. The guidance changed for PPE, you know, recently. And so now we are all getting masks and we're all getting the visors for the eye protection. Obviously we had gloves and we had aprons. So that's, you know, in an outpatient setting, things have changed. I think certainly it varies from hospital to hospital, how much PPE they have. I have colleagues working in a Northwest London hospital on an elderly care ward, for example, and not having access to proper PPE. Now, there were definitely COVID suspected patients on that ward, and this particular doctor had to order his gown from Amazon. Now, you know, this is not good enough, that he's having to source his own PPE. So this worries me. I think the issue of PPE is huge. I think as doctors and nurses, you know, we're asked the question, you know, would we go and treat someone if we didn't have adequate PPE? I think on our training is that, you know, yes, we would, but it's definitely a very anxiety-inducing situation if you haven't got the correct protection. And I don't think it's fair to say that there isn't adequate PPE. It's the situation that we're in right now. I mean, very latest guidance is to reuse certain PPE. So there is going to be a shortage. There was a shortage this weekend, and guidance was out, I think, on Friday. I'm not sure, but it was very recent. Maybe it was, you know, yesterday. I can't remember. But there was government guidance on the reusing of certain PPE. I think in certain situations, definitely you can do that. For me, for example, I wear a mask. I don't change it in between patients. I've been advised in my clinical setting to use the same mask for the whole clinical session. So that's what I do. But I'm not treating patients who have COVID. And those people who have suspected COVID, we are screening them. We're not actually seeing patients at the moment who we feel could have COVID. But with this infection, to be honest, anyone can have it. You just don't know. So all I can say is I don't want to get into the politics of it, but all I can say is that I really hope that this resolves soon. It's really tragic when you see healthcare workers dying and getting sick. It's very painful as a profession to see that. But I think, you know, I just, all I can do is hope. I mean, in the government briefing today, they did say there is PPE available. It seems to be the distribution of it that's the issue.
Thank you.
Could I please ask you about social distancing again?
Yes.
If we were to have family members or friends who we maintain social distancing with, but for argument's sake, they came down the side passage in our house and we were to sit on opposite ends of the garden, say 3 or 4 meters apart, is there anything wrong with that?
So how many people?
Perhaps just a couple of people.
I mean, if you're sitting at the opposite end of the garden, then look, it's more than 2 meters. Then is there any problem with that? Well, no, not really, because there are people walking around in, you know, in parks that are talking, you know, to people that are, but keeping an adequate social distance. I think if you're sensible with it, then there's no real issue with that if you're sensible with it. But it's when people start having large gatherings, then I do think it's a problem, because, you know, people tend to mingle, and if there are more than 2 or 3 people in a group, there is a tendency to just sort of edge in a little bit closer. So personally, I think if it's just having a conversation at the opposite side of the garden, I think that's fine. As I said, I speak to my father, I go and visit him, and he's standing on his balcony and I'm standing in the driveway, and we have a conversation. So I think as long as you're observing that social distance, I think that's okay. But when it becomes large groups, you know, 2, 3, 4, 5 people, I just wouldn't advise it. Why take the risk? Okay. We don't know, you know, we don't know enough about this virus at the moment. But we do know that it's a lot more infectious than we initially thought it was. So that's the concern.
Thank you very much.
Deepa, two questions, and I'm very proud of you. This is my sister-in-law. But 2 questions. What does a negative positive test mean? And the second question is when you test in a hospital environment, and do you test, can you get the result of that test within the day, within a hospital environment? You will give that result to that individual. So that's one. And the other one is, what does a negative positive mean?
So, so I think you mean what? So not negative positive tests. I think what you possibly asking me is the sensitivity of the tests. You wouldn't have a negative positive test, but you would have a false.
I've heard that terminology said to me. Is it
okay?
Can be a negative positive test, and I just don't understand it.
Okay, so I think what it's probably referring to is the sensitivity of the antigen test. Let's talk about the antigen test, okay? This is the test that we are doing to detect whether you have the virus at this current moment in time, okay? So it's not the antibody test to see whether you've had the infection, it's the antigen test to see whether you, at this point in time, have the infection, okay? So it's about 70% sensitive, all right? So you will test 70% of the population and it will be positive in those people, okay? 70 out of 100 people, but in 30 of those people, your test could be a false negative, okay? So they could have had the infection, but we just didn't pick it up, all right? So I think that's what it means is it's not going to pick up the infection in everybody, but that's the test that we have right now. And so when you want to, when you're looking for a good test, you want it to be highly sensitive. That means pick up all the true positives, and you want it to be highly specific, so it picks up all the true negatives, okay? Because the last thing you want is a test to show that somebody is, you know, negative, but actually they are positive, all right? Does that make sense? Okay, you need it to be
Yeah.
And in terms of the hospital infections, yeah, I think it is given back on the same day, but I'd have to check that, Ruth, because I'm not currently working in the hospital sector, but I would have thought so.
Okay, and then
actually, just to sort of give you another pointer, in hospitals, I know that if you're clinically presenting with COVID type symptoms, you are treated as COVID, whether you've tested or not. So, you know, the test sort of becomes, you know, good for surveillance, but if you're sick enough to go into hospital, then it's an assumption, you know, with those symptoms, then it's an assumption that you actually do have that infection.
And I'm sure there's lots of people on here that either assume or think, you know, and I'm one of them, that I've had it, and how immune am I? And I was listening to a friend today who said, you know, she doesn't want to go near anyone because she wants to fly out and see her parents. And I was thinking to myself, well, isn't it better if you've had it? But then nobody knows what the length of immunity is, whether you could get it again in a month, a year, or 2 weeks. So I often think, well, okay, so if I've had it, I'm immune, or I'm immune for a certain while. So therefore, I don't mean mingle within social distancing, but parameters, but just be able to do other things. And I think that's the confusion that a lot of people have got at the moment. They're going out and they're having these private tests to find out whether they are immune, whether they've got the antibody, and I don't know how true those tests are. And the other side is so is it a herd community thing? Do we want to have it? You know, do we want to know that we've had it and therefore we feel a bit safer? And I just think there's a massive, I'm not saying you've got the answer, but there's a massive confusion around that.
So if I take the first bit first, antibody testing at the moment, we don't have any antibody tests in the UK that is being rolled out, okay, because they didn't feel that the initial tests that I think the government ordered didn't feel that they were accurate enough, and they have to be accurate, really, and they weren't up to the sensitivity mark that they were happy with. There are certainly antibody tests around privately, but you have to be very careful with these tests, because the last thing you want is a test to give you a false sense of security that you've had this infection, okay, number one. Secondly, we don't know how long the immunity lasts for. We just don't know that. So just because somebody thinks they've had the infection, and you know, one may well have had it with the clinical syndrome, but we just don't know whether the immunity lasts for weeks, for months, a year. You know, we're guessing, really. There are other coronaviruses where we know that protection will last up to a year, but we're talking specifically about COVID-19, and we just simply don't have the data. Ruth, I've lost you. What was your second part of the question?
Sorry, I was just coming off mute. I mean,
what was your second?
The second thing is it better for us to know that we've had it? But I guess that's the first part of the question. How do you ever find out if you've had it? The government guidelines are, if you present any problems, whether it's loss of sense of smell, loss of sense of taste, your bones are aching, you just isolate. So most of the country and most of the world are isolating based on some of the acknowledgement of what might be COVID, and therefore I I don't know whether I've got a false sense of security thinking, well, I've had those symptoms, but I wasn't on a respirator, God forbid, a million times, I'm lucky. So have I really had it? I don't know.
We don't know. And I don't think you can make the assumption I've had it and therefore I'm fine. I just don't think you can make that assumption right now. We certainly need to have the antibody testing. It's going to become hugely important for surveillance afterwards. I mean, we have to ease lockdown at some stage. I mean, it will be done at some stage. There is no strategy right now, and certainly it's just too early to talk about it because we're still having, you know, although we had a reduced number of deaths over the last 24 hours, but we're still getting new cases. So it's still early days, you know, which is why the lockdown has been increased for another 3 weeks. But definitely antibody testing is important just to have surveillance and monitoring, because once we ease the lockdown, you do need to know how much of the population, you know, who's been infected and who hasn't, who's at risk and who isn't. And certainly for healthcare workers, it would really help them because they would feel safe and confident in going back to work. But again, we need more data, and that's why, you know, things are coming out month after month, you know, week after week, really, until we know more about this. We still don't know how much of the population is infected. I mean, if I just tell you, there's a small study. It wasn't even supposed to be a massive study. It was a small little study done in a German town, I think, where there was an epicenter of coronavirus, okay? And they randomly tested about 1,000 people from this particular town. And they found out when they did this testing that they did the antigen test, and 2% of those people actually had the virus at that time, and about 14% had the virus, okay? So had tested positive for the antibody. So when they overlapped these results, they said that in that community, there was about 15% immunity, which is a lot lower than, you know, what we're sort of saying is a safe level to be, you know, for herd immunity. I mean, I think herd immunity now is going to be produced by, more so by a vaccine. It's not really going to be produced by us, you know, coming out of isolation and roaming around and getting unwell with this virus. I think the strategy in the beginning, who knows whether, you know, herd immunity was the strategy in the beginning, but it changed very, very quickly when data was coming out that people were dying. So you certainly can't go through a natural herd immunity. I mean, I know Sweden is doing what Sweden is doing, and we will see what happens. It's still early. There are new cases there and deaths, so we'll see. But certainly this country, and I agree with them, it wasn't really a strategy when you're seeing a lot of people dying. Does that answer it about the antibody testing?
Absolutely. Yep.
Thank you.
Hi Deepa, thanks so much for doing this. I've heard in the news, in the newspapers today, that they're thinking about starting schools again, possibly when this 3-week period is that, or like sort of staggering years, doing like 1 year, 1 year group, 1 week, 1 year group. How likely do you think that is, or what do you think will need to happen for that sort of thing to occur?
I mean, I think that listening to the government briefing today, it's not something that's going to happen very soon, all right? Certainly not in this country anyway. I know in some countries they may allow students to go back sooner, but certainly not here. I don't think it's on the agenda yet. I think that when we come to easing the lockdown situation, and it's just too early to say when that will be, and obviously the government has talked about 5 strategies that it wants to, you know, 5 preventative strategies it wants to be, you know, certain about before they even talk about an exit strategy for this. But I think that schools may be one of the first things to open. Okay, and I'm just saying that very, very hesitantly. I don't know the answer, but simply because we know that, you know, the younger age group, if they get this virus, they recover from it, or they just don't get it, or it's, you know, just very mild. So, but then again, there's still going to be social distancing rules in the sense that we wouldn't want you to be visiting those at-risk population and the elderly population and grandparents and all that, that will still be, you know, in play if that government is, you know, if that's relaxed. But I don't know at the moment. Well, I do know, because I don't think it's on the agenda at the moment for schools to open right now. Sorry, I feel really bad about that. I think it must be awful for you. Must be awful just to interrupt your education like that. I'm, you know, I really feel bad about that. But I just think that definitely the young people will be the first to, you know, probably go out, and non-essential, you know, maybe small businesses, you know, I don't know what the strategy is yet, but at the moment we haven't got one. So I think you're at home for a while.
Is it not the case that if children are carriers, albeit mildly, that they have the same chance of passing it on to somebody as an adult?
Yeah.
So, you know, this thing with May the 11th that was in the papers today, Michael Gove obviously said that was a load of nonsense and he didn't know where it came from.
Yeah.
In the medical profession, do you have any better idea how long the lockdown will be?
No, I mean, I think if you, you know, we're looking at it purely from a medical perspective, okay? And we're still seeing new cases, and we're still seeing significant amount of deaths, although it has reduced, but we haven't seen a trend yet. It's only just one day's data where we see the deaths about 596 or something, you know, as opposed to seeing 883 deaths. Certainly, yes, it's encouraging, but it's one day. And we have to see a trend in the reduction of deaths. There's a plateau in the reduction of new infections, but it's just not robust and good enough and sustained at the moment to start talking about an exit strategy. We don't have any therapeutics at the moment. We don't have a vaccine at the moment. So if you're asking from a medical perspective, I think we have to continue the lockdown. Obviously, there are economic factors that the government has to balance as well. So that's really for them to decide. But if we're looking purely at the medicine, it still looks a bit risky until we start seeing a sustained reduction in the number of new cases and in the number of hospital admissions and in the number of deaths.
Deepa, hi. I wanted to ask you, if I lost a couple of weeks ago my sense of taste and smell, but I didn't have any other symptoms, no temperature, no cough, nothing. Does this mean that I got it and I'm fine, or does this mean that I got something else?
But, you know, really difficult to say, Dalia, because a lot of people have suggested this as a symptom of COVID-19, as you know, a lot of people have had these sorts of symptoms. The problem is, you know, these symptoms can also occur with any other respiratory tract infection. So it's not specific right now. We're saying right now to COVID-19. We can't say that. It's not still in the official list of symptoms. All right. But definitely, anecdotally, we're hearing this. I mean, I've had colleagues who've had this infection. They have had fever and a bad cough, and then they lost their sense of smell and taste. And then I've had people like you, you know, who have been relatively well with it, but have definitely noticed a change in their sense of smell and taste. So I'm sure it has something to do with it, but at the moment, I would be really cautious to say, yes, I think you've had it. I mean, did you have a test? You probably didn't test at the time. So,
then they made me have a test. It was negative.
Yeah. So I don't know what test you had, because I'm not sure what tests are available in the private sector, but without testing, you know, with the validated test, we couldn't say whether you had it. I don't know. It's possible. And maybe as we get more data, we'll see that actually this was one of the symptoms. I mean, we know from China, for example, a significant proportion of those patients there had gastrointestinal symptoms. You know, we're not seeing that so much here, or it's not being reported. And still the government guidance is around, or the medical advice, guidance is around persistent cough and fever and shortness of breath and fatigue and malaise. These are still the symptoms that we're recognizing as COVID-19. I mean, ENT surgeons, loads of them, have said loss of taste and smell is definitely one of these, factors. But again, I can't give you a complete answer.
Thank you.
Okay.
Deepa, one of the major components of an exit strategy is the testing and the ability to do very widespread testing. The government, even today, is completely confident they're going to reach this 100,000 figure. I mean, how realistic is that? Is that serious? And what does it mean? Is it testing, is it the antigen, or is it antigen and antibody? What does it mean?
Okay.
Yeah.
Yeah, so I think it's the antigen testing. It's to see how many people have the virus. I think that's what he was talking about when he was talking about ramping up testing, but also he's developing an antibody test as well. So he could be talking about combination of two, but my understanding was talking, about who has the virus at this moment in time. I mean, at the moment, only healthcare workers and people presenting in hospital are being tested. I think it's been extended to prisons and a few other people, groups of where testing is available. I mean, it's difficult to say. I mean, we're reaching 20,000 tests in a day. So I don't know whether 100,000 tests a day is going to be an achievable target by the end of the month. It seems optimistic, given that, yesterday we tested 20 or 21,000 people. That's way short of what he was suggesting he was going to test. So,
sorry to interrupt you, but I mean, they also seem to draw a distinction between the number of tests that they could do and the number of tests that are actually being taken up. And I don't know if that's, that's just sort of clever, politicking, or whether, there is something important in there. Are people resisting taking tests? I mean, what's that about?
I don't think people are resisting taking tests. I think you have to make testing easy, and you have to have lots of testing sites. So we have 27 in the UK. Okay. I mean, is that a lot? Doesn't sound like very many, but that's what we have, I think. And I think you need to make it far easier in terms of how you test. I mean, the test is easy. The test is a swab, and you can get results back within a few hours. For that antigen test, you can. I mean, I know that my colleagues who have tested, the result hasn't come back in a few hours. It's taken at least 3 or 4 days, but in hospital setting, it's definitely a lot quicker. I can't really answer your question as to what he's thinking, the Secretary of State for Health. Can he absolutely deliver 100,000 tests a day by the end of the month? I don't know. I mean, Germany, for sure, we're testing 500,000 people, and we're testing the general population, not just restricting it to certain groups. And that's why I think it's made some difference. I think there are lots of factors in play here as to how different countries have different figures. Okay, so I don't really want to just give a false sense of a sort of feeling that, oh, Germany did very well purely because they did all the testing. I think there are other factors, but certainly that was a very good strategy.
Thank you.
And not just testing. I mean, obviously isolating and contact tracing and all the other infectious disease things that you have to do to contain a pandemic.
We have time for one more question. Who's it going to be?
I've had a question already, but can I just ask you another question?
Yeah.
So with your expertise in HIV, do you see with your patients in HIV a spectrum of illness? And can you relate COVID-19? I'm baffled why some people are affected are asymptomatic, other people who look and sound like they're pretty fit and healthy. I'm not talking about the very elderly and the people with impaired health and that we know will God forbid be affected. But can you relate? I mean, can you tell me what we do to try and make sure that we are as fit and as healthy as possible to keep our immune system as effective as possible? I mean, is there something you can tell us, or is it all just sort of hit and miss?
It's a really, really interesting question, and it is a bit hit and miss in some situations. So, for example, we can't explain why a 90-year-old lady can be admitted to hospital with COVID-19 and recovers and goes home, and yet we're seeing 50-year-old men come in who are swimming several lengths a day and hugely fit, and unfortunately have succumbed to this virus and died. Now, clearly there are host factors at play, and we just don't know all these host factors right now. What can we do? I mean, I don't think supplemental vitamins or anything like that are going to make much difference. Of course, don't smoke, have a healthy, balanced diet, regular exercise. Certainly obesity has been considered to be a certain risk factor, so keeping fit and healthy is really the best that we can do right now. We can't say, actually, this particular individual is worse off. I mean, I'm talking about the general population now. We know certain at-risk populations, excluding the at-risk populations, the elderly and those with, immunosuppression and all the other quite sick people who are generally fit and well. Unfortunately, we have seen this virus, take its toll, and we don't know why they've had that response. We just don't know why.
Could I ask you a question?
Deepa.
Hello.
Hi. I read that there was a doctor in Richmond Times Dispatch who was on a ventilator for 2 weeks and recovered after 4 infusions of a drug for rheumatoid arthritis called Actemara. I don't know if you've heard about it.
No, but certainly drugs for rheumatoid arthritis, are being trialed. Like hydroxychloroquine has been used to treat, rheumatoid arthritis. Is it something to do with the inflammatory response, or the immunosuppression, or the immune pathway, dampening down the immune pathway? Is that where this particular drug has its effect? I mean, maybe, but we don't have the results of that trial yet. There's a big hospital trial going on right now called Recovery, and it is trialing, 4 different drugs: azithromycin, hydroxychloroquine, dexamethasone. What's the 4th one? Lopinavir, which is an antiretroviral drug, and it is trialing in separate arms against standard of care. Okay, so the control arm is people who are having standard of care with high flow oxygen and ventilation and these supportive types of treatment. So I think we're not going to really see much in the way of results from these big clinical trials until possibly June. But if they see that there is a positive effect earlier than that with any of these drugs, then certainly, we'll know about it. I mean, these drugs are being used in certain patients on compassionate grounds, but they're not given to everybody.
Okay.
Very you.
But if somebody who has rheumatoid arthritis and is using this drug, is he more likely to become ill or less likely?
I don't know the answer to that question, to be honest. I couldn't give you an honest answer. Are they more likely? I mean, the fact that they have a chronic illness and they're still on a drug that's helping that illness that may help against COVID-19, I can't really give you that answer. I mean, all I can say is, with my patients who are HIV positive, who obviously have an immunosuppressive illness, But those that are on antiretroviral treatment, we have not said that there are any, you know, increased risks than the average general population who is immunocompetent. They are just not. And thankfully, none of my patients have actually been seriously ill with COVID-19. They've been well, tested positive, but been well with the infection. Now, we could turn around and say, well, is it the antiretroviral drug that's helping them? Because, you know, is it?
Yeah.
Don't know, but certainly antiretrovirals are being trialed in this situation.
Righty-ho, everybody. Great questions. Thank you very much.
Thank you.
Deepa, thank you for a very informative session. And thank you for everything you and your colleagues are doing in the NHS.
Thank you.
Thank you, Deepa. It's wonderful.
Thank you very much.
Thank you.
Thank
you, Deepa. Thank you.
Thank you, Deepa.
Thank you.
Thank you. Nice to see everyone.